I think it comes as no surprise to people who know me that methadone is one of my all-time favorite opioids. Some people have even taken to calling it McMethadone in honor of my last name, I think. I think one of the most important things for practitioners to know is that methadone has some very unique pharmacodynamic and pharmacokinetic properties. You must be respectful of these, or you could easily get into trouble. Some of the benefits of methadone are it's a long-acting opioid inherently without being pharmaceutically altered. It comes as tablets and as oral solutions. We can even give a concentrated oral solution in someone who has difficulty swallowing. So that's one nice feature. It's very cost-effective, which is very helpful for patients who have difficulty obtaining their medications. And it has multiple mechanisms of action. It not only is a mu receptor agonist, it's an N-methyl D-aspartate receptor antagonist, and it inhibits the reuptake of serotonin. So you've got a lot going on with methadone that often makes it a good candidate to treat pain that has multiple pathologies going on. On the downside is methadone has an extremely long half-life, anywhere from about 20 to 140 hours, and it takes 4 to 5 half-lives for the drug to get to steady state. So a critically important thing for primary care practitioners to remember is once you start methadone, I try very hard not to adjust the dose before 4, 5, 7 days. Let the drug come to steady state before you start making modifications. Also, methadone could be the poster child for drug interactions. There are so many drugs that interact with it and can inhibit the metabolism of methadone, most notably. Some also induce the metabolism, but you're far more likely to get into trouble with a concomitant drug that inhibits the metabolism of methadone. I always ask my hospice nurses, is the patient on an antidepressant, an anti-infective drug, or amiodarone? Because those are the 3 big drugs or drug categories I worry about. And I think patient education and family or caregiver education is very important to monitor for potential toxicity evolving from methadone therapy. People don't go from starting methadone therapy to stopping breathing in the next day usually. So what you're looking for is increasing sedation and snoring, for example. So getting the family involved, educating the patient and the family, the caregiver, and making sure that everyone understands the very unique characteristics of methadone assure a much smoother course.